Hello, my name is Gwen Redler. My healthcare career spans over 25 years in acute hospital care. I am currently the nurse manager on a 47-bed medical surgical unit for a large Northeast healthcare organization. I am doctorate prepared, a graduate of Sacred Heart University, located in Fairfield, Connecticut. Thank you for inviting me to present today. I will share my evidence-based work, which is also published in the Journal of Gerontological Nursing. Mobility is medicine, right? We know it is, yet it was empirically evident that many of our patients were not ambulating, even with a hospital-wide protocol in place. The medical surgical unit I work on primarily houses older adult patients. Common admission diagnoses include sepsis, respiratory compromise, GI complications, alcohol withdrawal, and disease exacerbations such as congestive heart failure, Crohn's disease, and sickle cell anemia. Daily progression rounds include hospitalist providers, the nurse manager, acute care nurses, discharge planning nurses, and a physical therapist. This is when we discuss patient throughput and barriers to discharge. The patient's physical ability to take care of themselves at home is important to our decision-making process of where the patient goes after the hospital. On many instances, nurses could not speak to their patient's ability to walk independently versus the need for assistance during these rounds. The provider is unable to recommend a safe discharge to home without this information. This resulted in the need for a physical therapy consult and often recommendation for post-discharge inpatient rehabilitation if the patient lost functional ability due to time spent in bed. A literature search confirmed that this problem was not unique to my medical surgical unit, but a problem throughout the United States, showing that Fazio et al. Found that hospitalized older adults are spending 87 to 100% of their time in bed. Adults age 65 and older are at an increased risk for functional decline due to immobility, coexisting geriatric syndromes, and multimorbidity, increasing their risk for blood clots, delirium, weakness, and falls. Grayson et al. Discussed another consequence of immobility is functional decline. Patients who normally would have been discharged home require a longer length of stay in inpatient rehabilitation to regain the functional mobility that they lost. This increases post-acute care costs billed to Medicare and patient dissatisfaction reflected in hospital consumer assessment of healthcare providers and systems survey scores. When faced with time constraints and staffing shortages, mobility was prioritized as low and often missed, leaving institutions with established mobility programs lacking the staff to carry them out. Other barriers included fear of patient falls, patient acuity, and confusion as to whose responsibility it is to assess patients' mobility status. Patient mobilization aligns with the goals of the Quadruple Aim, National Patient Safety Goals, and the hospital's mission to improve the health and healing of all. I looked at patient mobility practices on the general medical surgical inpatient nursing unit and came up with a plan of how to implement best practice strategies of early and regular ambulation. The aim was to bridge the gap between the established progressive mobility protocol and staff's ability to carry out the recommended interventions. Common strategies included nurse-led mobility protocols, written guidelines and policies, mobility aides or volunteers, and designated ambulatory units. The hospital already had many things in place, including a progressive mobility protocol, order set, and policies, yet patients were not seen walking in the halls on a daily basis. The piece missing was a designated person solely responsible for ambulating patients. This being a school assignment, I developed a project that would meet our patients' needs and also the American Association of Colleges of Nursing DNP Essentials for Advanced Practice Nursing. Older patients, specifically patients 65 and older, who came to the hospital from home ambulatory was my target population. Discharge disposition was the measure I chose to quantify functional ability. Few studies investigating nurse-led mobility protocols included discharge disposition as a primary outcome of interest. I developed a problem statement as follows. In hospitalized patients 65 years and older admitted to a medical surgical unit with an initial mobility assessment of ambulation with assistance, does the addition of a mobility champion to an existing progressive mobility protocol compared to no mobility champion have an effect on functional decline, as evidenced by the percent of patients referred to acute inpatient rehabilitation post-discharge over a 10-week period? Virginia Henderson's needs theory provided the theoretical framework for the initiative. She believed helping patients with their basic nursing care was the foundation to the health of the mind and body for the sick and well alike, and that the nurse and patient share a mutual goal to restore the patient to pre-illness functional ability. The project design followed an evidence-based quality improvement model designed to improve outcomes of care in a local practice setting. The target population was patients 65 and older who were acutely admitted from home to an inpatient medical surgical unit. Inclusion criteria included patients who were assessed as ambulation with assistance upon admission and could follow simple commands. Exclusion criteria were patients younger than 65, admitted from a long-term care facility or nursing home, not assessed as ambulatory, could not follow simple commands, had a bed rest order, required an escalation of care during their inpatient stay, spent more than 48 hours in the emergency room prior to obtaining an inpatient bed, were transferred to or from another unit within the hospital that did not have a mobility champion in place, or recommended to transition to an inpatient psychiatric facility post-discharge. The setting. The implementation setting was a 47-bed medical surgical inpatient unit located within an 867-bed teaching hospital. The measure was recommended discharge disposition. The setting for chosen based on its existing progressive mobility protocol, and the majority of patients fit into the 65 and older class. The ethical, merit, and project approvals included the Implementation Sites Research Council and Sacred Heart University's Institutional Review Board. Project implementation process consisted of education and implementation of mobility champions responsible for ambulating patients meeting inclusion criteria. Mobility champions were introduced to the unit using daily huddles and weekly staff email updates. They were trained via hands-on education, including communication techniques, strategies to minimize refusals, infection control standards, safety precautions, handling of oxygen catheters and IV pumps, mobilization equipment, and documentation in the electronic record. Data collection and management. The primary source for data collection was a review of patient records using the electronic chart. It was used to extract patient assessments, mobilization events, length of stay, and discharge disposition recommendations. A retrospective chart review was conducted on patient admissions to the unit from December 4th, 2022 to January 28th, 2023. The mobility champions were implemented on January 29th of 2023, and data were collected for 10 weeks with a mobility champion in place, ending April 8th, 2023. Using lean daily management strategies, a Pareto chart was used to collect reasons for missed ambulation events. The mobility champions kept in constant communication with the nurses and kept a record of ambulation events as well as reasons for no ambulation events. To stay budget neutral, the mobility champion's full-time equivalent was taken from the allowed number of patient care aides for the floor. Data analysis. The retrospective chart review yielded 139 records. The average patient age was 78 years old. The average length of stay was 4.51 days, and ambulation events documented per day averaged 1.12. At the end of the inpatient stay, 67% of patients were recommended to return home and 33 were recommended to go to post-discharge inpatient facilities. There were 141 patients who met criteria during the implementation phase. The average patient age was 77.6 years old. The average length of stay was 3.89 days, and ambulation events documented per day averaged 2.78. At the end of the inpatient stay, 82% of patients were recommended to return home, and 18.4 were recommended to go to a post-discharge inpatient facility. The data were analyzed using IBM SPSS statistics. A chi-square test was performed and showed statistical significance of 0.005. The number of patients recommended to go to an inpatient facility post-discharge decreased by 19%. Anecdotal evidence indicated that the number of physical therapy consults and patient length of stay were decreased by eliminating the wait time for a physical therapy consult and referral and placement for those recommended to discharge to another inpatient facility. Strengths of the project included: the mobility champions expressed their buy-in for the mobility role. They shared the patient's enjoyment of the role as well. Many patients shared how they love to walk and were grateful to walk multiple times during their hospital admission. The hospitalist providers, case coordinators, and the physical therapy staff developed a relationship with the mobility champions and were able to make recommendations based on what they witnessed as the mobility champions walked with patients. The cost of implementation was low. After the original education hours needed to get the mobility champions trained, there was no added cost. Although many more ambulation events were documented with the mobility champions in place, patients continued to refuse ambulation for various reasons. An unanticipated finding was a few nighttime covering hospitalist providers were ordering bed rest inappropriately on new admissions. This, paired with family refusals to allow their loved ones to ambulate, shows that the belief that bed rest is good for healing still exists. Impact on practice. I am grateful that I have been offered the opportunity to share my work with others here, as well as previous engagements I was invited to. Again, my work is published in the Journal of Gerontological Nursing. This project contributes to nursing practice knowledge by confirming the importance of patient mobility in hospitalized older adults. It showed that mobility has a role in the maintenance of the patient's function and independence, and is a determinant of where the patient is recommended to go at time of hospital discharge. Implementation of a mobility champion filled the practice gap identified, limitations of staff and time resulting in low prioritization of patient ambulation. Discharging patients to home aligns with quality measures, including patient satisfaction. Decreasing length of stay has a financial benefit to the organization with a potential cost. It costs over $6,000 per day for a bed on an inpatient acute care hospital. Clinical practice guidelines and provider orders for progressive mobilization can be met in the face of staffing and time constraints. These are my references. Thank you very much for having me, and I'll take questions.